Well, after masterful lecture by Dr. O'Gara, we are ready for live case demonstration, and particularly towards end of his slide about the bicuspid aortic valve. And this patient is for the bicuspid, but we cannot hear Dr. Mehran clearly at present. But can you hear us, Roxana? No.
We hear you, but I wanted to introduce the panel. So let's make sure that you have we have live panelists from around the world. We have live panelists from around the world. I want to make sure that everybody introduces them perfectly well. We have Dr. Alexander Abazaid, who is has been a pioneer really in bringing in.
See, again,
tell them to show this camera. Tell him, show this camera,
no, this
not that camera. No, it's that camera.
He's the director of interventional cardiology in São Paulo, Brazil, in a brand new center, and I'm really looking forward to hearing all the things that he's doing right now, and I know he's going to have a fantastic addition. Eberhard Grube doesn't need any introduction. You all know that he is another innovator in our field. Without his incredible efforts over the last 20 years, we wouldn't be where we are today. Eberhard, welcome to our panel, and thank you for being a partner with us on this course. We also have my very good colleague and excellent interventionalist, structuralist, Dr. Didier Cheche from Toulouse, France, who's a true star and a PI of several ongoing prospective randomized studies, and I'm just so thrilled to have him here on this panel. And then, at last but not least, the infamous Michael Mack, our surgeon. He's here. He is really one of us, but he has really pioneered the field and is now leading the valve collaboratory with Dr. Leon, and just so wonderful to have all of you here on this live panel. So we now go back to lab 6. Dr. Sharma, if you would introduce the case for us.
Yes, and thanks all the panelists. We'll need a lot of advice and comments on this case. I just want to introduce a new member. So me and Dr. Keeney, everybody has seen, and Dr. Tang, we have the fellow here, Sunny Goel and Faisal. So 2 fellows, and we our anesthetist, the cardiac anesthetist is Dr. Eric Fried. So with that note, we start this case. And Stematos means and Stematos is on the echo section. You'll hear quite a bit from him. And these are all our the key participants for today, and the disclosures which have been shown earlier part of the presentation also. And we also tell after in between time for audience to go to the exhibit hall, which is again electronic. So this is the case, 77-year-old male presented with dyspnea on exertion and has the risk factors, as you can see here, most important being the T-cell lymphoma, going active chemotherapy, coronaries are okay, dilated ascending aorta, and also has some COPD on various medications, and was found, this was about a month ago, as a screening echo, was normal ejection fraction, was low flow, low gradient, with a mean gradient of peak gradient of 44, mean of 27, and the peak velocity was 3.3. It has changed a little bit, and we will show that now with the active live echo and comments from Dr. Stam Larakas. Yes, so can we go to the echo, please? Yes.
Yes, good morning from New York. I have on my left our structural imaging fellow, Dr. Anastasius. As you can see, this patient has normal LV function and normal RV function. Again, normal LV and RV on X plane. No much matter regurgitation. Normal strain, but -21. You can appreciate the aortic valve. You can appreciate the doming, which suggests that the valve is congenitally malformed and most likely bicuspid. Also, you can appreciate the dilated sinus of Valsalva, which measures about 4.1 centimeters. Also, the leaflets are thickened and calcified. This is the short axis view, which shows perfectly nicely that the aortic valve is indeed bicuspid, type 1A, with fusion of the right and left cusps. And you can appreciate the raphe here, which also is calcified. This is the no-coronary cusp. You can appreciate nicely that this type 1A bicuspid aortic valve.
Actually, that's a very good picture. Can you comment on, people talk about acquired bicuspid versus congenital bicuspid? How would you differentiate the fused commissures in the acquired bicuspid? Sometimes we do talk about that.
Yeah, I mean, this valve, you know, it looks that usually if it's acquired bicuspid, you can appreciate some that the commissure is opened a little bit, you know, between the cusps. Here is completely fused.
Okay.
So it's this looks like this congenitally bicuspid aortic valve.
Beautiful.
And this is the X-plane of the aortic valve again. This is with color, no much aortic regurgitation, mostly stenotic valve. Today, with the help of Dr. Malcolm Anastasiou, our excellent fellow, we were able to get actually higher gradients. As you can appreciate, the Vmax is 4.3, the peak gradient is 74, and the mean gradient 44. So by these measurements, also the previously was, by the continuity equation was severe, but today also by gradients and everything, the valve is severely stenotic, aortic valve area of 0.5 centimeter square.
And I think this is a very important point, that within 1 month, things have become from low flow, low gradient to a high flow, high gradient. And clearly the velocity is almost like became 70% higher.
Yes.
So this is what had been, but a paper from ours also in the COVID timing, when you want to defer these cases, the event rate occurs almost 10% per month, if either requiring urgent tower or death, these patients. So clearly underline that whole concept, which we have learned over the years, that severe aortic stenosis is a very bad disease and need to be taken quickly. This is a classical example, echo done at Mount Sinai, the numbers which I showed, 45-27, now became 74-42, 44, just doubled, I mean 70% more within a span of about 3 to 4 weeks. Yes.
Yes.
Stem, anything new you want to tell?
Yes, also that's an excellent point. And also many times depends also on the operator. You know, sometimes if you have to try harder, you can find higher gradients, but I agree. This case was done here, the velocity was lower, and in a month's time, the velocity is now into severe levels.
Okay.
And by continuity equation, both times the aortic valve area was severe.
Okay.
This is a full volume of the aortic annulus. We try to measure the aortic annulus with 3D, as they do also with CT. Sometimes when we cannot use contrast, we prefer this method. In this case, we did it just for demonstration. And as you can appreciate, the area of the annulus is 744, very close to what you will see the measure by CT. And also we are able to measure the height of the coronary arteries. In this particular case, the left main from the base of the annulus was 1.45 centimeters, which is also about the same as you can see the measure by CT. And the last view, this is the view that we use after the valve is deployed. This is a gastric view to evaluate the gradients and also to evaluate for valvular, but most important in this particular case, for paravalvular regurgitation. That's what I have to say. Back to Dr. Sharma.
Okay, all right, we can go back to the slide. So quickly present and then so this
Dr. Sharma, can you wait 1 minute?
Yeah.
Can you hear me?
Yep.
Dr. Sharma?
Yes, very well.
Okay, so first of all, we've got to fix some things here because you're not hearing me as I'm talking, and it's tough because I think this is a very important thing. You showed us a change in the hemodynamics, and I wanted to just see if the panelists had some thoughts about that because I think this is a really big teaching point. Samir, Mike Mack. Samir first, then Mike.
I think that in the bicuspid aortic valve, many times this is an important point that when you measure the gradients because of the eccentric jets, transthoracic wise, sometimes you cannot align to the jets properly. And so either invasive or a more detailed analysis is necessary when we think that the valve is calcified and not opening and the gradients are low. So that is my sense that this is probably related to the way now that with the TE, they aligned the jet properly. And with regards to the whether it is congenital or acquired, there is no real acquired bicuspid valve because most of the pathologies that we see are not really commissural fusion. So it is most commonly a bicuspid valve that is congenital. And now there is a very nice classification that a lot of people have worked on to say that what should be how much fusion of the commissures are there. And you can, and Michael Mack and others have written on this particular
Yeah,
topic.
so let's have Mike give us Dr. Mack
So
comments.
I'll give three brief comments, Roxana. I agree with Samir that the differentiation between acquired and congenital is an artificial one and really of no relevance in terms of clinical decision making. And virtually all valves are congenitally bicuspid. Secondly, as Samir said, you've got two different techniques, transesophageal and transthoracic, to be able to measure the jet. I don't believe that there was rapid progression in a 3 to 4 week period of time. It's two different techniques, getting different windows to look at it. And thirdly, you got a patient now under general anesthesia that's been unloaded, and that unloading by itself is going to increase the gradient. So I think those are the factors that explain the difference.
No, those are excellent explanations. And I think we are learning a lot now. We all got a mass email from Edwards about echo parameters in understanding hemodynamics versus what's happening. And I think we're going to have a very good discussion around this, because I think there's a little bit of madness going on, but absolutely correct about what you just said, that this is most likely a different view. This is definitely a congenital bicuspid valve. And now you're going to tell us the CT measurements, Dr. Sharma. We're back to you.
Yeah, so
thank you.
Actually, you can see the aortic annulus is on a larger side, which is anything more than 683. We call it large annuli, and area is 763 in this particular case. Maximum 36.6, minimum 27.4 with a mean of 32. So always question comes, what to do? Many times with a very large aortic annulus, we send them for surgery. But in this particular case, when active chemotherapy had a radiotherapy in the past, is not appropriate case, even otherwise a very low risk. So these patients basically resort to the tower. Gilbert, you want to comment on this?
Yeah, our group has published a multi-center paper on this, and certainly we've treated annulus this big, tri-leaflet or bicuspid before with the balloon expandable valve, and have quite good success as shown in the paper. I mean, I think what makes this patient particularly anatomically favorable is also the LVOT is a little bit smaller. If you look at the LVOT, we look at it routinely in terms of sizing as well. It's 631, so it's within actually the 29 sapien free range. So we feel pretty comfortable treating this patient. And if you look at the next slide, you can see certainly what Sam showed, the large sinuses and STJ are very large, and you can see the raphe actually is not significantly calcified. As everyone knows, the recent Raj Makar's paper looking at severe bicuspid calcification, the raphe calcification is a predictor of potential adverse event. In this one, actually, the raphe is not severely calcified. So we think we should have a very good circularization of the valve with this particular case. Next slide. And again, just to show you here, that's the hockey puck view. You can see the raphe on a 2 o'clock position. The upper right panel is not like a big spear. Certainly there is calcification, but we think you should be able to open it up with a pre-ballooning and balloon expansion. Next slide.
And the coronary heights are
yes, the coronary heights are well. Yeah, you can see that it is quite effaced. Next slide.
Yeah.
Access,
so before you go to the femoral access, let's hear the panelists, because this is a really
we'll do it now, but I know, but remember, we had to, we'll continue discussion while the case being done, because patient is ready. The sentinel was already placed, which is about 30 minutes, so we'll continue. So just wanted to complete the presentation from the vascular access point of view.
Go back. Yeah,
we
have Parasuram. Parasuram actually was our structural fellow, and right now he is the young structural attending of this program. If you can just focus on Parasuram, he's going to start talking on the femoral access.
Sure. Yeah. Thank you, Dr. Kinney. Thank you, Dr. Sharma. So the CT scan actually showed pretty much non-calcified and a long CFA portion. We chose the right side. And since especially the patient is on active chemotherapy, we always do a up and over bailout. So we actually got the non-main on the left side, and we actually have a V18 wire port and the ipsilateral SFA through the left CFA. Also in high risk cases, we get extra vein in case if predict like thinking if some complications can happen, then we can actually go quickly on the pump. So we actually have an extra vein in the groin as well.
Okay, so so then Arch, this patient already have the Sentinel.
Yeah.
I know the national data as of 2019, use of Sentinel was less than 10%, but clearly in our center, we make it like many others, that Sentinel as a default strategy, which is done in about 60% of cases and will show. And so, and basically the valve sizing here, knowing that the large annulus in this particular case, going to use a 29 millimeter, put additional 2 or 3 cc's of the contrast to really get to our area of 763. And this is basically sum up that low risk, but in a kind of extreme from overall point of view, although STS is low because of comorbid conditions and so. So this is where we are ready with the for the valve, and now Dr. Keeney is ready to cross the valve, and now we'll get all the panelists to discuss, but maybe we can just show one aortogram. This is a Sentinel device.
Yeah.
And the aortogram, and then we'll just start. This is the large dilated aorta, 4.1. And while Dr. Keeney is now going to cross it with the AL1 because of the large annulus, that's what we do. Otherwise, AR2 usually we use. And now, Roxana, you can have our discussion, our extreme panelists.
Well, thank you so much. So a really great case of a bicuspid valve. I want to hear from Didier Cheche, especially given that, the choice of the valve and here the Sapien is chosen. Is there a valve that should be chosen, one versus the other? And then we'll come back to Alex and Eberhard about neuroprotection and also some of these parameters. Didier, welcome.
Thank you. Thank you. Welcome. Good morning, everyone. So just to make it brief, I would say that for bicuspid aortic valves, you can use whatever device you want. Here it's more about the matrix of the patient. And as we are facing a very large annulus, we don't really know about what is the configuration of the supraannular region, but here I estimate that it's more like a flared configuration. So definitely the Sapien 3 is the most appropriate device with additional CCs. If the dimensions were a little bit smaller, an Evolut Pro would have done the job beautifully in that case also. So every device works. In this particular case, I would stick to the Sapien 3.
So what's your practice now in Toulouse? Are you feeling there's a little bit of a dilation of the aortic root here. Are you worried about the aortopathy? This is a 77-year-old man. Do you have any concerns about TAVR in a case like this?
So you're perfectly right, Roxana. This is a key concern when it comes to bicuspid. What are the dimensions of the ascending aorta? And when it is dilated, and if the patient is definitely not a surgical candidate, we will use the shortest device that we may have for this patient. And once again, the Sapien 3. Otherwise, if we have a normal configuration of the ascending aorta, we use preferentially in our center the Evolut platform for bicuspid valves, because of larger EOAs, very low gradients in this particular subset of patients.
I see you're already crossed the valve, Dr. Kinney. Thank you. We knew you would be there quick. Sure. Let's get a couple of more comments, and then we'll come back to you in understanding whether or not you pre-dilate, et cetera. Dr. Grube, any comments about the case so far and the use of neuroprotection? Would you ever go forward without?
Yeah, thank you, Rox. And I agree with DDA. I think you can choose whatever valve you want to choose, and the 29 Edwards is probably appropriate. The question to me comes up, and I might disagree with DDA on that, because there's still the jury out on what's the best sizing method. There has been proposed many of them. I don't think we have a clear message. In this particular case, whatever you choose is fine. But if you choose a self-expanding valve, because of the large annulus, I would most probably go for a 29 Evolut Pro or Evolut, because as you know, the valve will never be circular. I've never been really impressed by annular measurements, and so I would not oversize the core valve. The reason being that if you oversize, the valve is being pulled into the ventricle, which you don't want. So here I would probably go with a 29 Evolut or Evolut Pro. I would not dilate in order to make the sealing a little bit better. And I think the choice of neuroprotection is excellent here. In bicuspids, this belongs to the risk factor for embolic protection.
Great.
So we have
Alex,
crossed the valve. We have
comments?
AL1. Yeah, AL1
Yep.
crossed it, and now we are ready to post the pre-dilate with a 25 millimeter ZMAT balloon. So we are ready to pre-dilate. I mean, pre-dilate for before our actual tower insertion. I know there's a lot of concepts. Some people don't pre-dilate, some people dilate.
Okay. What is it?
And
150.
and it's the confida wire.
So what's
With-
your philosophy
PAVM.
on pre-dilation, Alex? Maybe we can hear from you, and
Yeah.
then we'll come back
Yeah.
to Dr. Sharma and on his philosophy.
I
Alex?
I think it's an important
Stop.
comment, Roxana, because for bicuspid, very calcified valves, I trend to pre-dilate to prepare the valve most of the time. So I think that Dr. Sharma has the same thoughts as I did. So I would prepare, and sometimes I even use for sizing. Remember, for bicuspid, we are never so precise in sizing. So I like to pre-dilate
somebody take
most of
this.
my bicuspid. And again, perhaps this would be a good
have wire.
candidate for. I'm sorry that they terminated, but calcified and bicuspid, it would be a good combination for Lotus. But that's okay. I think Sapien is a good choice.
Oh, for Lotus, I see. Okay. All right. So any other thoughts before we go back to the main room to see what's next? And maybe you can tell us exactly what you're planning next, Dr. Kinney.
I know.
Yeah, we've pre-dilated, and I think just to give the tips
Show
of
us the
crossing,
valve and
since
what
we
you
already
do.
know has a dilated, we have a dilated aortic root. We used AL1 with a straight Terumo wire. Now, bicuspid actually could be challenging to cross since it is fused raphe, and the aortic eccentric aortic opening could be challenging, but you are able to cross quickly here. Once you crossed with AL1, you change to pigtail, and then we go with our confida wire. We did the BAV like we said. Same. I think what the discussion is going on is to make sure the calcium and the raphe open up, and we will be able to get the valve to the position quickly rather than having some struggle to go through the fused raphe. So right now we have the valve. We just wanted to make sure two people always confirm the skirt is facing down. We have Gilbert Tang, who is going to be the first operator. I'm going to be the second operator, and the wire will be held by Parasuram, who will be the third operator. Very important, all the three operators know what their job is, and we're just going to go up.
You ready?
Yeah. Starting.
Okay.
Yeah. Let the wire go a little further. Yep. And this wire, the valve need to be adjusted to bring it on the balloon once into the aorta in this view, and try to move as little as possible. Keep your view, which you're going to implant. Yeah.
Mhm.
Good.
Please
Well,
go through the steps one by one, Gilbert. Gilbert, go through
Yeah.
the
So
steps
you know
one
what,
by one.
Gilbert-
Please don't assume that everyone is an expert here.
No, I know. So you see here the loader cap. If are they showing here? Yeah. The loader cap is already here, and you need the loader cap fully inside the sheath, so the valve goes in. And this is also an important step, that your valve should go in and will not through the sheath and come out of the sheath easily and not hit any calcium. There is a risk that the movement of valve could be stripped off at that time. Now the next step is loading the valve. Now it's a job of the second operator and the third operator. So the third operator is advancing the wire, and this is what I'm going to do. You release here and start bringing the balloon back. This has to be done in the straight part of the descending aorta. So you see the,
please show
that
them,
it's
yeah,
come down,
fluoro, exactly.
lock it, and then you still keep doing with a fine small wheel. You see here, fine adjustment.
Yep.
The distal marker of the balloon is inside. Now it's completely loaded. Lock, unlock, just to make sure there's no tension. Then you go use this large wheel to flex.
So it's important.
So it has to be
attention
completely
to make
flexed.
sure you see the sentinel device, so you don't end up interacting with the sentinel device as you cross the arch.
While Parasuram is holding the wire, he's advancing. I'm fully flexed.
Okay, we're going to cross the valve.
And Gilbert is telling the next.
It's important to tell
Please
the
show the
show the
fluoro.
anesthetist you're crossing the valve.
The fluoro is there.
Yeah, Flora's there.
On the right side, no?
Yeah.
Yes.
And now
Yes,
also
yes.
what I did is I unflexed a little bit. Okay. Now we have to bring this catheter back. So
back.
the balloon is sheath
Yeah,
back. Yeah.
the
So
valve
I'm
is
going to
across,
advance.
so yeah.
He's trying to
Yeah, good,
adjust it.
Okay.
And we
Again,
bring the
please.
pigtail back
So
down.
based on the calcium, you see that
So Maggie.
I think it's 70 iota 30 LV. We'll confirm it.
Okay.
So you bring the pigtail. Pigtail
right,
actually has to be in the
It's a big
non
group.
if we can.
The
I'm
right
trying
foot.
to. So to get it, what you do is come up, counter, keep counter.
Good.
That's all we
That
can.
will be okay.
Yeah.
That will be
Okay,
okay,
go in. It's not in the non.
No, it's okay. I think that's
Okay, some dye.
Yeah, it's better.
maybe
Non
that's
is
just big
fine.
root.
In this case,
It's a
it's
big
better.
root,
Yeah.
It's a
That
big
looks
root,
good.
so you can, that's
Good.
okay. To,
Okay, so
yeah.
now I got it in the right position. Some dye. What do you think?
Yeah,
Yeah,
tell
that's
next
pretty
step
good.
what you want to do now.
So no, now I'll unlock. If you see here, this is
Blood pressure is stable.
yeah, good, right?
Yep.
So are you
now we'll
using the
confirm
echo
position.
parameters now?
No.
No,
nothing
no,
yet.
right now everything
we
will be
see?
fluoroscopy. Okay, so I have Ramon who is on the pacemaker. So I will be the only person talking and giving instructions. So go 180. So I want to make sure the mean is less than 40, which is right now. Show the hemo, some injection. Okay, stop.
Okay, okay. Show the hemo also on the left side below. And this is the time where you tell everybody is in the same page. You tell our cardiac anesthetist also that we are going to go up, because remember, compared to, I always say, with the surgery, the whole process is slow. It takes time. Slow in the means that it's accumulative. And here is all or none. So everybody should be ready in case there is a problem in getting the blood pressure up. Give a rapid doses, high doses of epinephrine to bring the pressure up. But anyway, so they have been seen. Position is good. Now ready to deploy.
Everyone
Okay.
is agree on the panel?
Yes.
Yeah, I
Okay,
think the
180.
panel likes the
I'm going to
position.
take the pigtail.
Yep. Good.
So
Sure, no,
I'm ready to go up. So blood pressure is 40. Slow inflation. You see the valve coming out, and now I go full. Now, when I go full, I want to make sure I complete zero expansion. Zero. Good. Few seconds there. I pull back.
And you keep pacing.
You stop pacing?
Stop pacing.
Or
Continue.
when do you
Yeah.
stop
Now.
pacing?
You only
Yeah.
stop pacing after the balloon comes
Yeah.
out.
Once the balloon is completely deflated, you stop pacing.
Okay.
And Eric, the anesthesiologist, is paying attention to give increase the blood pressure.
Yeah, but the blood pressure is good. It's coming up.
Yeah.
Yeah, it's coming
Yeah.
up.
Resuscitation was, nothing unusual happened. Many times, particularly people with a low ejection fraction, it takes time to bounce back. But this case right away came back.
Looks
Pressure
very
is
good.
good.
Looks
There's
very
a
good. How
para-
much?
Now we get the echo. Now
There's
we
some-
can take the
there's something
hemodynamic
here.
out and put the echo below, please.
At 2 cc. 2 cc.
There's some paravalvular leak,
Yeah.
I see,
Yes.
right?
Yes, there is.
Yeah.
See on the left screen?
That's at least mild there.
Yeah.
I would add the,
At least mild
Let's do it.
paravalvular regurgitation.
But let's ask the panel. We go with 2 more cc.
Yeah. So
sure.
what do you all think? There's a little bit of, it's not severe. It's like mild to moderate, maybe
no.
mild, I would say. Is it moderate?
Yeah, mild, yeah.
Can we
No,
see
no,
it?
it's
You want to bring the echo
Can
on
we
the
see
main
the
screen
jet?
and just
No
to
need.
analyze?
Okay, this
Yes,
is good.
yes.
This is good. You
No,
can
we can see
Okay.
it. Just show us the jet.
okay. Can you explain, please?
And in this
What
particular
does the
case,
panel
knowing
think?
that that PVL, a young guy, and he's supposed to have good prognosis of his CLL. So we will try to maximize. They put an additional 2 cc's before. They can put additional 1 or 2 cc's. We knew that annulus was very large. So not unusual, add 2 more cc's while balloon of the valve is still there, and go back and with additional 2 cc's because it's still mild plus. It's a mild minus or mild plus. So this seems to be mild plus by our echocardiographic team. STEM,
Yes.
speak, please.
Yes. Can you see the long axis? So I say it's mild, good mild paravalvular leak. Yeah.
Now, since we know the annulus is benign and no risk of perforation, either we can post-dilate. We should go ahead and post-dilate. Let's put 2 more cc's and we'll go again.
Anybody on the
Tia,
panel
please,
would not do this. Didier, Eberhard,
You want
Alex.
to do aerogram first?
I
It's,
believe that in this case, there is a need for post-dilatation, but I think that there was one thing that could have been done slightly different in the CT analysis is understanding what is the configuration of the supraannular region. Because if you have something that is way larger than the annulus, you're not going to get a device that is going to seal properly. So if you have a tapered configuration, the risk of the ability to seal everything with the supraannular region makes sense. Here, probably we have a flared configuration, so there may be a residual regurgitation because it's a very large anatomy. But it's already a very nice result, I have to say.
All right. No, this is a really good point. So the supraannular
150
ridge
again?
configuration.
180. Eric, we are post-dilating.
As they're post-dilating, any comments, Eberhard, Alex?
I think I would like to mirror Didier's point. I think this is what we see when you try to circularize in a large annulus. You know, there will be some leak, and I'm doubting.
Okay, stop.
You know, that you get rid of it.
Okay, now we come out, right?
Yeah.
It's still there.
Okay.
Yeah, and I think that's what Didier was saying, that based on the CT, Dr. Kinney, that it may be that you will not be able to get this paravalvular leak be gone just based on the way the valve is positioned and the configuration of the valve and the configuration of the supraannular ridge by CT. That, you know, you did your best, you went up a little bit, you post-dilated, you gave a couple of more cc's, and what he's saying, and I think the rest of the panel are agreeing, that you're not going to get rid of this little mild leak.
Do the aortogram now. Okay, we'll do the aortogram. Yeah,
we'll put a pigtail in first, Dr. Sharma.
Because
what Gilbert, you agree with that?
Yep.
Gilbert?
Yeah, so Didier, we actually Didier, we
aortogram.
actually look at the supraannular aspect of it. I mean, because of dilated root, you know, we know that it's going to be larger than the mean diameter that you measure at the annulus. I would say it's probably around, like, I don't know the exact number right offhand, but it's probably around mid-30s or 35, 36. If you look at, let's say, a commissure distance. But I think the other thing that's different about this particular anatomy compared to other bicuspid anatomy, as you saw, is that there's really no supraannular calcium. You know, in terms of that might constrain the valve or make it a potential a bit better seal. So it's pretty benign leaf-like calcium overall. So we've actually started doing post-CT in some of these bicuspid patients and show that even if you add volume to an undersized valve, it really goes up to about 31 millimeter in the frame dimension at most. It's not like going to go to 33 or 34. Indefinitely, you know, so I think there is going to be some limitation to how big you can expand the S3, at least in the patient versus on the benchtop model.
Can we re-zero everything?
We go put the catheter and the pigtail in the LV now to show you some hemodynamics.
See it here. We can see it now. Show the hemodynamics now. You're done. Yeah. Good. Hemodynamics looks very good. As you see, there's no gradient.
Looks good.
Diastolic pressure is good. Yeah.
Yeah, you can see that despite the mild PVL, the diastolic pressure in the 60s, in the 50s, 60s, and
can we get the TE up?
Yeah. Yep.
And I will show you the aortogram as well.
Yeah. We are going to show the aortogram.
Yeah, we typically do an aortogram to check the final position, coronary flow, and all these other anatomic parameters.
Okay, inject.
Yep.
All right.
Very good.
Looks very good.
Looks really, really
so
good.
You can see with
fantastic
we also
results.
like to implant these valves a little bit more high position.
Yeah. No, we noticed that. Can you just give us the plan for the follow-up of this patient?
Yeah. So basically, right now we are still in the same of the aspirin plus clopidogrel for 3 months. I know with the popular TAVI you can make it only 1, but still the guidelines have not come through. So this patient will be on aspirin and clopidogrel and follow up, of course, in-house echo tomorrow. And knowing that no need for any pacemaker, likely will go home tomorrow, pending any full protocol of the post care, which is what our 2 structural fellows do. And the plan will be 30-day follow up, and of course at that time do all the KCC questionnaire and show frailties and indices which are requirement by the TVT registry, and then 1-year follow up. Many of these cases now having a Zoom or telephonic consultation. With that note, if it's okay, I know we are behind the.
Well, 1 minute,
I also wanted
Parasuram,
to
just say
just
how you will complete closure. Let's finish one
yeah,
second.
the
You tell,
closure
how
and
you will
also
close.
about
Closure,
the aorta. There is a aortopathy here. I want to know what you're doing about follow-up of that aorta. And then of course, the closure. So those 2 things, and then we got to go because we're a little bit behind.
Yep, right.
Sure. So we'll take the sentinel out first now, and then we usually reverse anticoagulation, give ACT back to baseline, and then we already have a wire from the contralateral non-main axis side. So we routinely go with a balloon and then balloon tamponade, even before we actually go down on the proglide. And then once we are done with the balloon tamponading and locking the proglides, then we take a final angiogram, just make sure that the axis side is okay. And then close the non-main axis side as well.
Okay, good.
And the yearly follow up for the aortic root dilatation, aortic size, which is 4.1 now, and we know that limit is 5+. So that's a long way to go, and hopefully, who knows, in 5-7 years, maybe appropriate ascending aortic dilatation cases will be done percutaneously also, transcatheter wise. With that note, we complete our presentation of the live case, and you go back to your important hot topics, Roxana.
Well, no, thank you. I want to thank the panel. We're going to come back with, thank you so much for all of the great work. And thank you,